Hi everyone, my name is Cindy Lopez and I did my presentation on co-occurring disorders along with Tanika and Wendy. So I did part A of this project. So I'm going to do the case study, the client's biopsychosocial assessment. Some identifying information on our client. Her name is Mariana. She is 32 years old. She's a female. She identifies as Caucasian. She also identifies as heterosexual. Mariana is of German descent and she considers herself to be Christian. She is separated but did conceive her one and only child from that relationship. Mariana did drop out of high school, but she earned her GED. Mariana is considered to be lower middle class and she works as a cashier at Walmart. So some medical concerns and issues on Mariana are that she does have an issue with stimulant use, and the stimulant use has caused some brain damage. Mariana also has schizophrenia, which has landed her in psychiatric hospitals. Mariana has had child and youth services involvement. Mariana has poor mental health and poor decision-making skills, and they've restricted her from active involvement in her child's life. Mariana's child is currently being taken care of by someone else. So the presenting problem in Mariana's case is that she's just having a hard time sustaining a normal life. Mariana often has outbursts with customers as well as with co-workers at work. And she doesn't have a good attendance record at work to begin with. She calls out a lot and misses a lot of work due to her substance use. So like I said, Mariana has issues at work through negative outbursts and encounters with the customers. She has been close to losing her job several times due to customers making complaints against her. Mariana's father has a history of substance abuse, which caused him to be pretty much absent in her life. Mariana's mother was under a lot of stress most of Mariana's childhood due to being a single mother, and that resulted in a lot of emotional abuse against Mariana. Mariana also struggled with building and maintaining relationships as a child as a result of her poor relationships with her parents. In her teenage years, she began experimenting with substances to fill those voids that her parents left from her childhood. As far as diagnoses, Mariana is diagnosed with schizophrenia, which falls under the schizophrenia spectrum and other psychotic disorders category in the DSM. Mariana is considered continuous unspecified for her episodes and a moderate schizophrenic. She is also diagnosed with a stimulant-related disorder, identified as cocaine, and also moderate. For special population, I'm going to talk a little bit about prevalence and the impact of Mariana's disorders. So for substance use, it's present in all ages, races, socioeconomic status, genders, sexual orientations, you name it. Substance abuse does not discriminate against anyone and can happen to any and everyone, no matter what type of environment they grow up in. It does have a slight genetic factor to it, as well as environmental, in Mariana's case, where she has been exposed to the disorder through her father. And then the prevalence for schizophrenia. Schizophrenia is also genetic and can be onset in childhood or in early adulthood. And typically those who do end up diagnosed with schizophrenia have a typical normal childhood. The impact of these disorders is that substance use disorder and schizophrenia have very similar presenting symptoms. So in the case of Mariana, who has both, it may be a little bit difficult to navigate which disorder is causing which symptoms. So that could be a little bit of a problem. And about 5% of those who suffer from schizophrenia die by suicide, and about 20% attempted at least once. So I thought that was pretty impactful because those are pretty high numbers for such a heavy topic. And then for theories, so I did choose 2 theories that apply to Mariana's case. And the first theory is systems theory. So for systems theory focuses on how different systems such as family, work, church can have an effect on other parts of your life. So in this case, Mariana had poor family support growing up. She doesn't have a strong connection to her religion, which really rules out the support of like a church group or fellow church members. So I thought that systems theory really applied to Mariana's case. Another theory that I thought applied to Mariana was the social learning theory, and this theory focuses on behavior being learned through what we witness as acceptable. So I found this relevant to Mariana's case through her father's part in her life. So Mariana grew up with a father who also suffered from substance abuse, which exposed her to the disease the disorder at a very young age. And so I think that Mariana saw it as her norm and acceptable that her father was in and out of her life and using substances. So that's why I thought it was applicable. As far as the history and culture, Mariana grew up pretty emotionally abused by her mother, who took out most of her stress of being a single mother on Mariana. And her father, who was in and out, added to her emotional instability. So her teenage years were particularly rough, as they are for most teenagers. But that's where she began dating, and it was especially hard for her because she didn't really have a good idea of what it was to have and maintain a healthy relationship with anyone, because she didn't really have one with anyone in her life. So she began experimenting with drugs to fill all the emotional voids that her parents caused her in her early childhood. So Mariana identifies as Christian because of her family, but she doesn't really remember the last time that she attended church. She's very disconnected from her religion, and she's very disconnected from her German roots, which weren't of much help to her in her struggle. So as far as the special population practice, I chose 2 articles that I thought kind of aligned with Mariana's case. So the first one is the impact of substance use disorder on families and children from theory to practice. And this article just goes over the impact of substance use on the entire family and not just on the individual who is suffering from substance use. So the authors talk about how substance use is really made up of genetic and environmental factors that contribute. So, I mean, with Mariana, her had the genetic factor of substance use. Her dad was a user, as well as the environmental factor of witnessing how her family saw that as acceptable. And then the author stated that individuals suffering from substance use disorder cannot be treated, or even went as far as saying as they cannot be understood without involvement from the family, which would be particularly hard for Mariana because of the lack of involvement in her life in general. The second article that I read was called "The Perception of Substance Abuse Prevalence and Causes and Socioeconomic Status." So this study was pretty similar. It consisted of 100 drug users from all different rehabs. And the study kind of found the same thing. Issues multidimensional. And they also found that some of the main causes of substance abuse included using for fun, using because of peer pressure, and using for pure curiosity, which was not the case for Mariana. But they also found that some of the main they also found the same main results, which were really that family involvement is really crucial to recovery, that you can't really get much done if the family is not involved. So like I said with the previous article, this kind of related to Mariana because she doesn't have family involvement, so it would give her like really low chances of recovering. And so I thought I saw the connection there, and that's why I chose those 2 articles. And then this is my list of references, just my DSM and the 2 articles. And yeah, that's all I have. So thank you.
Hi everyone, my name is Wendy Medina. I did my part on interventions for the individual. So I'm going to talk to you about dialectical behavior therapy. So for my individual, her name is Mariana. She has a history of substance abuse and she is diagnosed with schizophrenia. So these are the assessment tools that I'm going to use. So one of them is the DSM criteria for substance-related disorders and for schizophrenia. I found this really cool website that this one right here, you guys can, this is the link to it, but you pretty much type in like on the search bar what kind of screening tools you're looking for, and it will give you a whole list. So I just typed in co-occurring disorders because that's what our project is based on. And I just went through the list of them. There was a few pages of them. And I picked out the ones that were related to substance abuse and schizophrenia. So ACCOD, that fully assesses for concurrent mental health and substance abuse disorders. ACCOD stands for co-occurring disorder screen, and it basically helps identify the possibility of co-occurring disorders, and you need to be fully assessed for mental health and substance abuse. It takes less than 5 minutes to administer, and there are 17 common behavioral health questions. The next one is CODSIMD. That screens for mental health disorders, and it's usually used for prison inmates with a history of substance abuse. It is highly accurate, and it distinguishes if further psychiatric assessment services are needed. The PASUPP, that stands for Problems Assessment for Substance Use in Psychiatric Patients. So that assesses population-specific problems. There are 54 items used for assessing that population-specific problems, and it measures frequency, intensity, and certain time intervals. And the last one, RESUS, it stands for Reasons for Substance Use in Schizophrenia. So this assesses reasons for substance abuse in individuals with schizophrenia and other psychotic disorders. There are 3 subscales in this one, and it contains items related to coping with distressing emotions. It contains items related to social acceptance and related to improvement of the internal, emotional, and physical scales. So the level of care recommendation, I had to do it on dialectical behavior therapy, which is also DBT. I actually never heard of it prior to doing this project, but I learned a lot from it. It is actually a form of cognitive behavior therapy, and it's a treatment that is used for individuals with multiple severe psychosocial disorders. The primary goal of this form of therapy is to transform negative thought patterns and destructive behaviors into positive outcomes. And weekly DBT sessions with the therapist, they're bi-weekly group sessions. Well, that's what I recommend for my client, Mariana. Slide, I don't know what happened. Okay, here it is. All right, so for a theoretical framework, it is abstinence-based, cognitive-based, it has a collaborative approach, and it is support-oriented. For abstinence-based, it pretty much means that it maintains total abstinence from non-prescribed opioids as the ultimate goal, but it views any failures to meet that goal through a harm reduction lens. For cognitive-based, it helps with identifying thoughts, beliefs, and assumptions that typically make life more difficult. The collaborative approach is there is a continuous amount of attention to relationships between the client and the therapist, And support oriented, it helps individuals identify their strengths and keeps building on that so the individual can feel better about themselves. So the techniques and tools that is used in DBT therapy is capability enhancement, generalization, motivational enhancement, capability and motivational enhancements in the therapist, and there is an environmental structure. So for capability enhancement, it provides opportunities to develop additional skills like regulating your emotions, mindfulness, distress tolerance, and other things. Generalization. The therapists use techniques to encourage the transfer of skills in all settings. So the client should be using the skills learned in therapy at home, in their school, work, community, in the family settings. For motivational enhancement, individualized behavior treatment plans to reduce problematic behaviors that may negatively impact their life. For capability and motivation therapists, the therapists receive a lot of supervision, the ones that do the DBT therapy. There is a lot of burnout in this. I mean, it makes sense, right? Because it's for extreme emotional and other disorders. And the structure and environment is there is positive and adaptive behaviors, and they are reinforced across all environmental settings. So the therapist usually helps out with this. They're not going to recommend the client go to a group session therapy that's not going to be motivating to Mariana. Okay, next for the individual, the treatment plan. So I created some treatment goals for Mariana. So one of them is to decrease her abuse in substances. For her, it would be cocaine and weed. We want her to promote healthy behaviors such as making new friends, reaching out to past friends, and attending events that support abstinence. Mariana should also learn more acceptable behaviors at work so she can sustain her job. I know that she is very close to losing her job because of her behavior outbursts that she has. So we need to change her behavior there. And a long-term goal is for her to be reunited with her child, and so she can be able to attend family therapy sessions with her child. For time and sessions, I recommend her doing DBT weekly sessions for 1 hour each. There's also group sessions that she can do, which that would be bi-weekly. She is free to do more if she wants to, or if she feels that it helps her a lot. I want her to do daily journaling on problem behaviors, mood regulation, and triggers, that can help her out with her areas that she is struggling at work with. So she can probably journal every day once she gets home from work if she has a tough day. There should be an on-call therapist because she may be self-injurious, or if suicidal thoughts occur, that may happen if she is, abstinent from the drug use. And the treatment is going to be ongoing to maintain, and we will titrate her DBT therapy as needed. So the strengths of DBT, of dialectical behavior therapy, is that it addresses harmful behaviors that are barriers in improving patients. It promotes target behaviors to overcome addiction, and it develops effective strategies to manage stress and regulating emotions. The weaknesses is, since there are a lot of skills to learn in DBT therapy and a lot of homework outside of the actual therapy session, it can be overwhelming for some individuals and they may just give up and, start using again. It requires a lot of working on yourself outside of therapy sessions. Like I said, it requires a lot of homework, and The client should definitely be using the skills learned outside of therapy, in the community, at home, at work. And it requires a lot of highly trained professionals. So there is more education involved for the therapist. And since treatment is ongoing, it may get pricey over time. I'm not sure how it works with insurance, if insurance covers it or not, or maybe a person doesn't have insurance and they need it covered. So for methods of evaluation, we are going to use the same screening tools that we used at screening. So we're going to use the ACCOD, the CODSIMD, the PA-SUP, and the RESUS. The reason for this is because we want to see if there was any improvement in the intervention of DBT. So we're going to use the same ones. And we can perform them monthly, every 3 months, and so forth. I guess it all depends on the client and how much improvement we're seeing, or if there's not improvement, then there can be some tweaking in the amount of therapy depending on the results of the assessments that are performed. So the prognosis for the individual, with the use of dialectical behavior therapy, the Mariana should be able to change her behaviors using the strategies that she's going to be taught by the therapist. And it is a form of cognitive behavior therapy. I mentioned that earlier, but it adds other techniques that are designed just for each patient. So every patient is going to have their own unique technique for themselves. So one of the articles that I read, it pretty much tells us what dialectical behavior therapy is for substance abusers. So it is called dialectical behavior therapy for substance abusers. So the article focused on providing informative facts and approaches of this form of therapy. It was developed by Dr. Marsha Linehan, and her goal was to help individuals to have a life worth living. That was her main goal of this approach. So one of the approaches used in this therapy is abstinence, which occurs only with promoting change. The therapist asks patients to commit to stop using drugs immediately and to commit a length of time that the patient is confident that they're going to achieve. So this can either be a month, a day, or even just a few minutes. And with the client achieving their goal, even if it is just a few minutes, they can keep increasing the amount of time so they can, promote change and be abstinent for a longer period of time. If the patient does fail, then the therapist helps the patient figure out the events that led up to the drug use and guides the patient to make a quick recovery. So this is why journaling is important as well, because we can see what happened in the course of the day that led up to the event of using drugs again. The second article that I found, it was called Dialectical Behavior Therapy in Adolescent Residential Treatment, Outcomes and Effectiveness. So this article was based off of adolescents in residential treatment, but there was a lot of information on adults. So it has been effective in adults with various diagnoses. So it wasn't just substance abuse disorders or schizophrenia, it was other diagnoses. And there is an adapted version created for adolescents. I forgot to write it, but it's called DBT, but there's another 2 letters at the end, and it's for, adolescents. It is successfully used in treating eating disorder, substance use disorder, treatment-resistant depression, and it reduces symptoms in obsessive compulsive disorder, schizoaffective disorder, and schizophrenia and PTSD. DBT happens in hierarchical stages that are aligned with symptom and problem severity. It starts with pre-treatment stage, and that focuses on commitment to treatment goals. The stage is supposed to target by decreasing life-threatening behaviors and increasing behavior skills. So I found this little chart online and it shows you pre-treatment is 4 to 6 weeks. This is the goals and interventions. Stage 1, the targets and interventions are listed here. Stage 2, targets and interventions are again listed. And stage 3, targets and interventions are listed again. So that is all. I've ran out of time. So these are my references. All right. Thanks for listening.
I will now cover the family portion of the presentation. To gather information from the family, a self-assessment screening tool, such as a questionnaire, can be used for gathering information. Observation can also be used as a screening tool and self-report instrument. A multi-generational genogram is a useful tool for recording this information, per Bowen. A multi-generational genogram is a pictorial display of a person's family relationship and medical history. An assessment of each screening tool is comprised to analyze how the family functions affect the family member individually. The screening tool is also used to assess the emotional impact on the family, such as anxiety. The level of care recommendation for this family is family therapy to motivate each member to work towards taking responsibility for their own change. Multi-generational family therapy is a theory by Bowen that seeks to identify how the family's current dysfunction is a result of generational patterns. The therapist focuses on facts rather than the family's thoughts, feelings, and emotions. Bowen believed that anxiety stimulated a person's emotional system, which leads to automatic and uncontrolled behavior. In families, anxiety is aroused by struggles within the families and pressures toward togetherness. The underlying premise of all concepts is chronic anxiety, which is an inevitable part of nature and life according to Bowen. Bowen defined anxiety as the arousal of an organism when perceiving a real or imagined threat. The treatment plan for the family is that Mariana will complete a relapse prevention workbook and write a summary of how she will incorporate this into her life of sobriety. Mariana and her daughter will attend family therapy sessions bi-weekly to identify how to improve their relationship. Mariana will identify at least one activity that she and her daughter can engage in on a weekly basis, and Mariana will also attend one NA meeting weekly. The intervention from the clinician will be to process the relapse prevention strategies with the family and discuss how sobriety has played a role within the family dynamics. A treatment plan should be measurable and achievable. A relapse prevention workbook will be a good first step in the treatment plan since Mariana struggled with substance abuse, and the substance abuse caused a lot of problems within her family. Strengths and weaknesses. Multi-generational therapy seeks to identify how the family's current dysfunction is a result of generational patterns. Multi-generational family therapy is a therapy by Bowen that seeks to identify how the family's current dysfunction is a result of patterns, and the therapist focuses on facts related to the family rather than the thoughts, feelings, and emotions of what the family thinks the problem is. Some of the strengths include generational patterns can be identified. Generational patterns can be interrupted to promote positive outcomes. And the goal of therapy is self-differentiation, which must be self-motivated by the individual and not initiated by the clinician. Some of the weaknesses are patterns are not easily broken. It may be challenging for people to break out of their patterns and to start forming new habits. Parents may also resist suggestions for family therapy. There could be personality conflicts. It could also be a challenge for children. Methods of evaluation include reassessing the family problems with these self-assessment screening tools during time of engagement in therapy. You can compare the screening tools from the time that the family started therapy to the time that they have completed therapy. Have the family members identify what was learned during therapy compared to when they first started. As the clinician, you also want to make sure you are evaluating the progress throughout the therapy. Highlight the benefits of therapy and how the family benefited from this intervention so that the family can also recognize the progress that they have made or also identify any barriers. If Mariana and her family follow the treatment plan, her prognosis is good, evidenced by active engagement in family therapy, the family verbalizing less conflicts and barriers to maintaining healthy relationships, and the client has remained sober and clean from illicit substances for the past 6 months, which is the duration of therapy. Client and daughter reports less anxiety, improvement in communication skills, and utilizes positive coping skills. Mariana can also benefit from the positive coping skills when interacting with her partner that she is no longer with. Client is also engaged with the support system to help her in her recovery and acknowledges that family is able to now take responsibility for their actions. Client and daughter have gained insight into generational patterns that may have been impacting family function. References. Thank you.